Hi, I'm Pam Abner, and I'm here at Aspen Ideas Health. Currently, I serve as the VP and Chief Diversity Operations Officer at Mount Sinai Health System, and I'm joined by two of our clinical leads, Dr. Lynne Richardson and Dr. Cardi Smith.
Hello, I'm Lynne Richardson. I'm the founding co-director of the Institute for Health Equity Research at Mount Sinai, and I'm the Mount Sinai Professor of Emergency Medicine and Health Equity Science.
Hi, my name is Dr. Cardinale Smith. I am the Chief Medical Officer for the Tisch Cancer Hospital and VP and Chief Quality Officer for the Tisch Cancer Center.
Thank you. So, Dr. Richardson and Dr. Smith, we had a wonderful discussion panel this afternoon, and let's just talk a little bit about that and some of the takeaways. What are some of the things that you want to share, especially around the discussion around structural racism, right, and how that impacts disparities in marginalized communities? Can you just share some of the, what you think about that?
Well, I think we had a good conversation really explaining to people how research can be used to help understand the way things work, why disparities exist, and what we have to do to change them. And this idea that so many of the things that adversely impact communities of color when they're in the healthcare system really come from inequities that are embedded in our policies and our practices. They're not bad acts by an individual, but they do have very detrimental impacts on individuals and the way they are cared for and ultimately on their health outcomes. And
right.
Cardi, I think, gave a great example of that.
Right.
Yeah, thanks. I think it became really clear that people really like to hear stories.
Yes.
Right? Stories help us understand impact and what it means. And so I shared an example from my own work where we are aiming to help improve the communication among physicians and particularly oncologists and their patients. And one of the things we found were that in conversations of patients with their oncologist, oncologists spent 3 minutes less with their patients who identified as Black and Hispanic when compared to their patients who identify as white. And I think there are several reasons why this happened. When we went back and listened to these audio recorded conversations, and these were conversations that were really enriched because these were patients who were coming in for a scan visit. So scans either showed that the cancer was getting worse or it was doing okay. But when we listened to these recordings, we found that particularly patients of color were less likely to use assertive responses with their physician. They were more likely to be deferential. And more importantly, we found that there were less empathic opportunities. So when patients were given bad news, they didn't open up and invite conversation with their oncologist to really discuss what that means to them. And I think that really goes back and harkens back to these structural and systematic processes and racism that has existed that really doesn't let patients engage with their physicians, because if their experience is that, why would I open up to someone who's never helped me move forward, that is then going to translate into differences in their care and differences in their outcomes.
And Dr. Richardson, you spoke specifically about kidney function, right? And we noted that some of the members of the audience were pretty much shocked to hear about what we refer to as the race correction factor. Can you just, talk about that a little bit?
Yeah, I think this is an excellent example of the way things get embedded in systems. So for a long time, healthcare organizations were using a way to calculate kidney function that had a race correction, so that if you were Black, there was a certain factor added in. And the result was that Black patients' kidney function would look like it was better than it actually was. And the result of that is that they were less likely to be referred to a specialist, they were less likely to be prepared for dialysis, they were less likely to be eligible for transplant. And this really came from some flawed data that had been done many years ago that got embedded in the system. It was in our electronic health record, it was in our laboratory information system. So everybody was using this flawed formula without realizing the ways in which it was disadvantaging Black patients. And when researchers started to look at this, and it really came from clinicians saying, what I'm seeing in my patients doesn't jive with this number in terms of what their kidney function is, and researchers took a look. We saw that the basis for this formula was very flawed. when we looked at large data sets, there really is no reason to correct the kidney function calculation for race. And Mount Sinai was one of the first institutions to actually eliminate the use of this race-based correction in the way. We removed it from our laboratory information system, from our EHR. We did education to clinicians about why suddenly their Black patients' kidney function seemed to have dropped. It's like, no, it was actually that bad all the time, but we weren't calculating it correctly. And we also went forward to professional associations, and that advocacy resulted in the national organization in charge of transplants changing their policy so that all hospitals that do transplants have to now use a race-neutral formula to calculate kidney function. And as a result, there are patients now who are eligible for treatment by specialists, for medication, for dialysis, and for transplant, which is a life-saving therapy, who before weren't eligible because it was flawed. So that's an example of how something got baked into the system. People didn't understand, but it was systematically resulting in poorer outcomes for Black patients.
Yeah, and when we say baked into the system, not at Mount Sinai, but this is on a national level.
Across the
board,
country,
across
the world,
Across-
really,
right.
people were using this formula. And that really led us at Mount Sinai to do a larger scan of all of the clinical algorithms being used in all of the departments to look to see were there race-based corrections that were flawed or inappropriate. And we've eliminated some things that we had been using for many years as a result of that work.
Right.
And that was work actually done by my Institute for Health Equity Research. So
Absolutely.
we're very proud of that.
Excellent.
Well, and I also think it's just a really great example of how an observation led to research, led to generation of evidence, led to going out and changing policy, and then going back to advocacy to change outcomes for patients. And that's really what we're striving to do.
That's exactly right.
Right,
Yeah.
and then one of the questions that came up, and we discussed this at length as well, is so. And you noted during the session, Dr. Richardson, that a lot of these disparities and these inaccurate capture of information or misuse of data have been going on for years. You pointed out that you had presented information meant for years ago, and nothing's happened. So, when we think about addressing disparities, like what is it, we just want to kind of wrap up with it. What is it that's getting in the way? And then what would be your one thing that you would say, this is what has to happen, or your wish, or what should happen for us to really address disparities ongoing?
Well, I think a lot happened during the COVID pandemic when the disparities in outcomes in the Black community from COVID were so stark, and unpacking the reasons for that, the reasons why Black patients were more at risk for contracting COVID because of the kind of jobs they had. They couldn't work remotely. They had to go out, use public transportation because they work as, bus drivers and in grocery stores and in nursing homes and so on. And because of the underlying burden of illness from these long-standing health disparities, they were much more likely to become seriously ill from COVID and much more likely to die from COVID. And so it really shone a spotlight where every day everybody is looking at the data on the news about how many cases and who's dying, that I think elevated health disparities to a new level, and to help people start to understand it's many things. It's not patients who don't have the education to know how to take care of themselves,
Right.
or
Or
who
blaming,
don't go to their
blaming the
doctors.
victim, like you said.
That
Right.
it is a system where there are structural barriers to them getting good care, and lots of things that adversely impact their health that are not addressed by our healthcare system. And so really using research, as Dr. Smith said, to drive changes in practice and new policies to dismantle those structural inequities that are baked into our system. This is really what's happening now. And for me, in healthcare, embedding quality into for me, embedding equity into the measurement of quality is the one key thing that every healthcare organization in the country should be doing, because we can level the playing field in healthcare and eliminate healthcare disparities. And that will be a big piece of improving outcomes.
Thank you.
Yeah, and I think I'll lead with my one big thing because it picks up on that measure, that quality measure, right? Because I think we identify those measures, and those are things that institutions could do now, as you said and pointed out, And from a bigger perspective, from a policy level, I think we have to be moving towards a value-based payment system and away from fee-for-service. We have to focus on the things that we know improve care and improve health outcomes and not volume, right? It really has to be on quality over quantity. And, you know, if this were easy, it would have been fixed, right? I think that it's going to require all of us in all of our areas to form a multi-leveled, a multi-tiered approach, right? We need to increase the workforce diversity. We need to add more clinicians, physicians of color, right? I know that you lead and work a lot with pathway pipeline programs to be able to do that, right? We have to be able to drive the research that's going to do it, and then we have to be able to partner with our policymakers to be able to do this and scale it.
Yeah, great. So I think, you know, just to summarize as we did this afternoon, you know, absolutely necessary that we need funding to address all that you both have just shared. And I also like to kind of wrap it up with saying that, you know, really for us to move forward, there has to be a greater understanding of the need and what's happening in our marginalized communities. Absolutely, things have been, you know, kind of amplified for us after COVID. So there's more attention to it. But, you know, that deep understanding of where these things are, and as you say often, Dr. Richardson, how deeply embedded in structure. This is not, you know, these things are there and by intention, and we have to unravel them. So thank you for sharing your insights. It was wonderful spending time with you today.
Thank you.
Thank you.